sessions on the highly relevant topic of composites in pediatric and aesthetic dentistry. I'm sure this session will provide us with valuable clinical insights and help us better understand the role of composite in achieving predictable function and aesthetic outcomes, particularly in pediatric dentistry. And here are the details, a few details of our upcoming offline and online sessions. So this is SnoozeCon. For the first time in India, a dental college is hosting a sleep conference, including dentistry, ENT, pulmonology, and other medical fraternities. Our most sought after training program, a 3-day my functional training program, which is having a very limited seats, will be conducted on 31st October and 1st of November 2026 as well. And BIMT, which is an advanced master training program, which is eligible for fellowship in Manipal, with very few limited seats available, most of our courses. And this is a 2-day aligner session on mixed and permanent dentitions as well, which will be held in September 4 and 5. Like I said, there is few seats available coming up. And for more details, you can contact in this number. And on behalf of everyone present here, I extend a warm and a heartfelt welcome to Professor Dr. Rajesh Ahal. So we are truly honored to have you with us today, and the stage is virtually yours. Thank you.
A very good evening to all of you. I welcome you to this platform on online dentistry. My deepest gratitude to uh, all the people in online dentistry for having facilitated this webinar. Uh, Online dentistry people had connected with me about 2 to 3 years ago, and they wanted me to share this program as well as other programs with them. Uh, it was a final nudge from Dr. Joby and Dr. Binu that allowed me to, I finally took the decision to be here with you all today. My deepest gratitude to all of you who, after having a hard clinical day on a working day, have joined today to be with us. And I would like to share my philosophy of things that have evolved over a period of time. Now, in the late 1980s, a lot of studies had been done in Southeast Asia regarding, and it helped in the evolution of a concept called as the atraumatic restorative technique, or ART. So initially they used Fuji 2 GIC, and soon or later they introduced reinforced glass enamel cement, which was later on called as Fuji 9 GP. So Fuji 9 GP, or the glass enamel cement, became a very important part of our treatment because it was easy. It had an anti-caries effect over a period of time, and also it bonded with the tooth structure. So for a pediatric patient, it was quick and easy. But as times evolved and I started reviewing my own cases after some time, I realized that some of these restorations, especially in the proximal areas, they underwent some kind of degradation. And when that happened, uh, I started to think that how would a degraded restoration would cause issues over a period of time. So today, I would like this session to be interactive. I'll be putting across some queries. So please do keep your chat boxes open so that you can see the responses and you can follow it up. Coming to the main topic, composites in pediatric and aesthetic dentistry.
Sir,
Now,
sorry to interrupt, sir. Your
Sure.
screen is not shared, sir.
Okay. I'll go back. Okay. You can see it now?
Yes, sir.
Thank you. Thank you. So, as thank you, Dr. Sandra, for having introduced me. And as uh, I belong to Jammu. Jammu, many people think it is as hilly as Himachal or Kashmir. No, Jammu lies at the plains, and just a kilometer outside, the hills start, which we call as the Trikuta Hills, and later on, the whole of the Himalayas start. So Jammu is always warmer by 2 degrees as compared to Delhi in summers, and it's colder by 2 or 3 degrees as compared to Delhi. So sharing this view of Trikuta Hills where the sun has risen, and I'm sure that the sun will rise on online dentistry also. So starting on with my this thing on composites in pediatric and aesthetic dentistry. Now, many of us feel that restorations by composites using composites in children is a very difficult task. No, I would first, it's not as challenging, it's as simple as doing a composite restoration in adults. So this is my, uh, you can see the difference that is that what we can be so much creative with the we can be so much creative with the composites. So I feel that the composites can be aesthetic, durable, and versatile, even in pediatric reconstructive and traumatic rehabilitation. I would love it to share my experiences with you, and I'm sure you can put all and most of this in a clinical practice starting tomorrow morning. So now, I would request you to open your chat boxes and please share in your experiences. What do you think is the lifespan of a composite restoration? 1 year, 3 to 5 years, 7 to 10 years? What do you think? So I'm sharing as you type in your chat boxes this case that had I done in September 2007. Now this is a restoration that has been done in glass enamel cement. Can see that margins have the margins of the restorations have broken down. There's micro leakage, and the surface is not smooth. So we did a restoration using a material that was very popular in those days. It was micro hybrid. So the patient came back after 19 years. The patient is now an ENT specialist, and this is the restoration that has been done. So there's no marginal loss of integrity. The surface has attritioned over 19 years, and I'm made to believe that this is the longest documented case of composites ever recorded. And this case has now been accepted for publication in Clinical Dentistry Journal of Indian Dentalization. And in that, all the steps have been shared. So please watch out for this. But this restoration, though done on an adult, I mean on a permanent molar, still signifies that restorations with composites are longer lasting than what we had thought. Now, for the sake of this webinar, I am not going into much theory because theoretical aspects can generally be discussed in a offline or in a hands-on uh, courses. But in webinar, I just sharing this aspect so that you can relate with what I'm going to share with you today. Macro felt composites came when I was just entering into my third year of bachelor's program. And at that point in time, I saw my seniors struggle with this restoration. Most of the patients came back with high points and tenderness, and they would have difficulty in removing the high points. So the macro-filled composites gave way to micro-filled composites, and micro-filled composites were considered to be a big boon as compared to macro. They had the aesthetics, everything, but the micro-filled composites got worn off very easily. So then they decided to amalgamate the two and come up with a hybrid composite. Hybrid composites, I remember, I did my first case during my internship, and it was so easy to do. The hybrid composites went on to be further modified towards the end of the last century, somewhere around 2000, somewhere around 1996, 97. Micro hybrid composites were introduced, and in fact, the previous case that I showed you with a 19-year follow-up was done using a micro hybrid composites, and the material was Z250 from 3M SP. By 2005, nano filled composites were introduced. We got them in India by about 2006, 2007. And with the introduction of nano filled composites, there was a paradigm shift in the composites. The content, apart from bisgama, it also contained something called as tech DMA and UDMA, which had a higher translucence, and that meant better aesthetics as compared to the previous group of composites. The nano-filled composites also resulted in a greater depth of cure that further decreased the polymerization shrinkage and in turn resulted in a higher strength. Nano-hybrid composites were also introduced, but honestly, I've never got to use them. And in 2015-16, nano-cluster composites were introduced, and it changed the things for me. Now, the nano-filled, the composites that we've been using are also uh, in, available in different form. They're dispensed in different forms. The paste form is the most popular. Most of us are using the paste form of composites. And the flowable composites came towards the end of the last century. They didn't have much strength initially, but today, and at that point in time, they were used more for preventive resin restoration techniques. And the but today, a nano cluster flowable composite, as I will share in my subsequent clinical cases, they have achieved strengths almost equal to that of a paste form composite. Somewhere around 2010, 2012, bulk filled composites were introduced. Despite the difference was that we were not using composites in that much increment. They were using thicker increments. So I remember using bulk fill initially, which they said was 4 millimeters depth of depth could be placed in one go and restored. And despite placing them in bulk, the polymerization shrinkage was still less than 1.5 and 1.58%. Recently, there's a material, a bulk fill material has been introduced with the name of Wonder Bulk Fill by Pediatric, and you can do a bulk fill of up to 8 millimeters depth. Uh, the fiber reinforced composites, they further enhance the strength of the composites. One of my very close friend, Dr. Krishna, she puts a sheet of fiber in her composite restorations to get beautiful results. The ones that I've used is from GC. It's called as Posterior X, and I've used it mostly for endodontic reconstructions in permanent teeth, what we call as a core buildup. So composites can also be segregated into multi-shade, single shade, and composites with chameleon effect. Now, I remember that ever since I started using composites very widely, majority of the composites would always be available in the single shade systems. I remember seeing an advertisement in a Canadian dental journal way back in 1997 where they had introduced a microfilled composite in different shades by a company called as Bisco, but unfortunately that was not available in our country. And the multi-shade composites came uh, later on. So I'm going to show you three photographs. Please open your chat boxes and number them number 1, number 2, and number 3. Now, can you please find out one where the restorations have been done? And second, which photograph is a multi-shade, which is a single shade, and which one is a restoration with a chameleon effect. So now coming back to the discussion, the single shade, we would, even despite giving a longer bevel, at times we would have issues. We would see a slight difference in the hue or the saturation. So whereas with so that is why the composites chameleon effect were introduced way back in say 2012, 2013. I remember using them by, again, introduced by GC by the name called as Solar. And they the whole idea was that when you restore, the restoration that we had done would take up the shade of the adjacent tooth structure. So that's why they were called as with the chameleon effect. Recently, I've used from with the one called as Omnichrome. So, uh, so these restorations you can see uh, have been done. Now, this is one restoration. I mean, the one proximal restoration done here and one here. So you can see the difference in the restoration. Second is here, and the third one is here. So can you still point out? So I'll share and please check your answers. I feel that whether you've been able to. So this is a multi-shade restoration. This is a class 2 restoration that has been done. This is a single shade restoration of class 3. And this is the chameleon effect. So this is the difference that composites can do today. Now, when we are planning to restore a tooth, it is very important for us that we also think of a tooth, say, in the anterior tooth or the posterior tooth as shared here, in such a way that, remember, the enamel will have a greater translucence in the incisal one-third. As we move cervically, the enamel will have less translucence, and the same thing for dentine. The shade of the dentine from the incisal to cervical changes. Uh, it becomes darker, and the same thing can be seen in different aspects of the molar for enamel as well as for the dentine. So when we have to reconstruct, we should think that which shade I'm going to use and how I'm going to apply to get the perfect shade match. So the reconstruction has to be in such a way that we're going to reconstruct the dentine as well as the enamel where the carious lesion has gone to that particular depth. In the subsequent slides, I'll also be discussing how the effect of the decay on dentine. Should we remove the whole of dentine to get that social media effect, or should we mask it to get the same effect? Because minimally invasive dentistry stands for minimal removal of the restorative material. Now, why do we need to have longer lasting restoration recesses teeth? I'll just break off from here for a few minutes because just about 5-10 minutes ago, I faced a small glitch, and somehow the video in this one is not working. So I'll go over here and I will start this video for you. Yes. Now, this video was shared by one of my very dear friends way back in 2006, and so I don't know where he got it from. But as the deciduous dentition shifts to the mixed dentition and there is growth, and in deciduous dentition, we do have, in majority of the children, spaced dentition. So there's always bound to be a food impaction. And when the food impaction occurs and you don't have good maintenance of oral hygiene, decay will start occurring in the proximal areas. If you're not able to restore the decay in time, that decay might either go deeper and affect the pulp, or will also affect the adjacent permanent teeth in some cases. Now, when that happens, if you're not able to conserve the milk tooth, then the tooth distal to that either drifts mesially or tilts. Now, when that happens, the leeway space of Nance is lost. And when the leeway space of Nance is lost, we have less space for the premolars to erupt. So the premolars will either erupt buccally, lingually, or they'll get impacted. Now, the best space maintainer is a deciduous tooth by itself. So if you're able to restore the deciduous tooth, then it will maintain the leeway space of Nance. And if the tooth has to be removed, then we have to give an artificial space maintainer. But just in case, as you know, some parents don't follow our guidance or counseling, and once the molar tooth has measly migrated or it has tilted, we need to distalize the molar depending if the second molar has is erupted or is in which stage of eruption. Now, to move a molar, we need a very good anchorage from all the other teeth. So it is a big challenge. So these things can be done by a pediatric dentist or it can be done by an orthodontist. So the whole idea of restoring teeth in such a way that the teeth should, the restorations last longer and we're able to maintain the leeway space of Nance. That is the whole idea of, you know, intercepted, interceptive pediatric dentistry so that we can have as less as possible as the need for interception by or corrective orthodontic treatment later on. Now, I'm going to share only 5 clinical cases, and I'm sure they will uh, encompass everything that we've been discussing so far. Before I start sharing the clinical cases, I would also like to share that documenting children is much more difficult than documenting the permanent the adults. In children, at times we have to start with the restoration, and the documentation can only start once we have the trust. So, in this child, the first case is that of a full mouth rehabilitation and also components of interceptive pediatric dentistry. So, the child came to us at 5 years of age in March 2021. The first thing that we did was we were able to restore the 7.4 and 7.5 using nanocluster paste form composites. And the child also allowed us to treat the pulpily involved 6.485 with a partial pulpectomy. Now, I had wanted to place stainless steel crowns on this child where the partial pulpectomy had done. Again, uh, the drawbacks of social media. The parents did not want the steel gray color of the stainless steel crowns, so we offered them the the composite or the porcelain crowns. Now, probably the cost factor made them not come back to me for the further treatment, and the child only came back to us 3.5 years later. When she came, the child was in this condition. So this is the 6.4 that has been, the composite restoration has been done using a nano cluster paste composite. These are again nano cluster paste form composites that have been done. And so the 7.4, 7.5 were like that. And the 8.5, which we had done a partial pulpectomy, has lost its restoration and it is quite badly affected. So subsequently, an OPG was taken. So when the OPG showed that the partial pulpectomy was doing fine in 6.4, this restoration in 7.4, 7.5 were doing good, but there was root resorption and furcation involvement in 8.5. So now I will take up the case, share the case in a quadrant manner. So when I do that, we'll be able to see what difference the restorations we've been able to do. So in the maxillary right quadrant, 6.4 and 5.4 and 5.5, so the radiograph shows that 1.4 is erupting, and also eruptive path. The 5.5 is decayed. 5.5 restored with nanocluster paste form composites, and 16 months later, the restoration is still doing well. The margins having a very good integrity. There's no degradation of the restoration, and 1.4 is erupting as let's 6. So over to the maxillary left quadrant, the 6.4 that had undergone a partial pulpectomy earlier, 6.5 decay. The radiograph shows that the distobuccal root of 6.4 has dissolved because 2.4 is on its eruptive pathway. There is decay on the 6.5. So 6.5 has been restored, and 16 months later, the restoration is still doing very well. In the mandibular left quadrant, These restorations, if you can recall, were done 3.5 years later, and this still doing very well. The marginal integrity is doing very well. And 5 years later, after these restorations were done, the and this photograph shows they're still doing good. Now, majority of you who have joined in today, they might feel that why have I not removed the uh, the dentin that has been discolored here. Now, this, see, we have to understand that in deciduous teeth, the pulpal horns are higher. Second, if I end up excavating or removing just to get a social media effect to share, I might end up creating a pulpal involvement and causing a and needing an iatrogenic causing an iatrogenic pulpal involvement, resulting in a pulp therapy that would need to be done. Now, the basic aspect of minimally invasive dentistry is that the more the tooth structure we save, the longer the restorations will last. And the longer the restoration will last, the better we can preserve the leeway space of Nance. So I'm just going to share a tip here. If we go back to our textbook on oral pathology, Schaeffer, the decay in dentine has, once it moves away from the pulpal level to the occlusal level, uh, this does not mean that it is in the pulp. What it means is the decay from the pulpal level towards the occlusal level. The first zone is a fatty degeneration of Tome's fibers. The second zone is that of a dentinal sclerosis. And the third is a decalcification. Now, these three zones are what we call as the affected or abnerated dentine, and they are the clinical boundary of bonding. The fourth zone, which has a bacterial invasion, but and in this case, there is a greater chance that the dentinal tubules may be intact. And then we have the soft, mushy, decomposed dentine, that is zone 5. So the zone 4 and the zone 5 together form the infected dentine. So when we are doing minimally invasive dentistry, when you're using a spoon excavator, we should always remove infected dentine and retain the affected or abnerated dentine. I'll be sharing a case where we have reconstructed the tooth with abnerated dentine very shortly in the subsequent slides. Uh, Now, some would feel that this may not be possible for the permanent or the permanent anterior teeth. Well, depending upon the depth of the decay, this is still possible. There are materials by which we can mask this and still recreate the original and get the original color of the restorations. So uh, I would, I'm one person who's into minimally invasive dentistry, and I do not, uh, for the sake of a very good photograph for a social media post, I would not remove the affected or abnerated dentine. Now we continue the follow-up of this case. Uh, the lower right, where the 8.5 that we done a partial pulpectomy earlier, has been badly affected. So the radiograph shows definite root resorption and also the furcation involvement. And the 4.5 tooth bud, the crown completion is yet to take place. So we restored the 8.4 with nano cluster paste form composites, and the 8.5 we extracted and placed a reverse band and loop. The reason why a reverse band and loop was placed, because over here the opercular flap was very fibrous, and placing a band would have been very discomforting for the child. The tooth extracted, and we can also note that there is less space for the canine over here. So I'll be coming to that part sooner or later. 2 weeks later, we have a good healing, and 16 months later, the 8.4 has resolved. The band and loop is removed because 4-5 is ready to erupt. And once that has been removed, there's sufficient space for 4-4 and 4-5. I'll come back to this part in the next few slides. Now, a panoramic view that have our restorations using composites helped in preserving the leeway space of nines and allowed the premolars to erupt well. Let's see. In the maxillary arch, a month later, this is the view. The restorations are doing very well. The 6-4 and 5-4 have not exfoliated as yet, but 16 months later, the 1-4 and 2-4 have erupted. The restorations are doing fine. And let's recall that the dimension, mesodistal dimension of the distal second molar is slightly more than that of the premolars, and there'll be enough space for the premolars as well as the canine to erupt. Now, our concern was this arch, and in the lower arch also, as I said here, the 4-3. So this was before we started, and these restorations were done 3.5 years late before. So 4 months later, 3 to 4 months later, this was the situation. And later on, where the time just before we removed this, so this was the situation. Now, we have been able to preserve the space for the premolars. We counseled the parents that we need to do an interceptive analysis to bring about, create space for the canine here, as well as for the slight uh, irregular teeth in the maxillary or the V-shaped in the maxillary arch. So this is the general label view that we are sharing from the beginning till the end. And now this is the radiograph was taken, the OPG, where we did the analysis for the intercepted pediatric dentistry in February of this year. We have tried to connect with the parents and call them back for a discussion, but they are following the good old ways of the stainless steel crown that had happened 5 years ago. So in this OPG, you can see the first quadrant, the second quadrant, and third quadrant. There's ample enough of space for all the teeth to erupt, but there is slightly less space for the canine. And if the parents do not come back, we're going to have probably a rotated premolar, the canine here, but that's what we can leave it at that. This is the best we could do. Now, I am also an avid cyclist. So on 1st and 2nd of May this year, we took a trip to a beautiful place which is called as Bhadarwa. And this town is in the it's even it's one of the most sought after tourist destinations. So the tourist department requested us to introduce endurance cycling into the region. So 35 people of we together rode into Bhadarwa over 2 days, 200 kilometers. The ascent was very high. In some places, it was as high as 10 to 12 degrees, and the descent was even more difficult in some places, going as high as 25 degrees. So it was a big challenge, but all 35 of us made. So the next day we went to pass beyond Bhadrava. So that's me, that's Dr. Ritu, and that's my younger son, and some of us. I can see the beautiful scenic beauty. So, or any one of you who would love to come to Jammu, J&K, and enjoy and see the beauty, please go to Bhadrava, and we are always there to help and guide you. Now, the first case that I showed you was where we had shown restorations, composite restorations done where the tooth enamel was normal. Now, in the second case, we have a child suffering from amelogenesis imperfecta, a hypoplastic amelogenesis imperfecta. Now, this child first came to us at 5 years from near the border, and that was January 2021. And so at that point, we could only restore the 8-4 with nanocluster paste form composites. The child came back 5 months later and required a pulpectomy. The parents became very scared And when they were informed, so they did not come back until 2 years later. And at that point in time, the child allowed us to do a pulpectomy of the 7.5. The 8.4 was re-restored, and 6.4, 5.5, and 5.4 was also restored using the nanocluster paste form composites. The child, this photograph that you see, she only allowed us to take this in January 2024. So a slight flashback to 6, 7 months before when we did the partial pulpectomy. Can see the decay involving the 7.5, involving the pulp, and we've done the partial pulpectomy, and you can see the restorations that we've done using nanocluster paste form composite. In the next case, I'll be sharing how step by step I've gone about reconstructing these teeth using composites. So now coming back to 6 months, when the patient allowed me to start documenting. So this was the condition that she came in. 7.5, we've done the pulpectomy here. Now, I was able to access certain very good articles on treating children with emergence imperfecta. And this article was published in 2021 in the Journal of South Asian Association of Pediatric Dentistry. The case has been published, has been done in Sri Lanka, and the authors there in Sri Lanka shared that preserving as much tooth structure as possible is highly desirable, as restorations will need to be replaced several times. They also talked about the different preventive measures that could be done. The bond strength of resin to enamel is decreased due to higher protein content in the affected enamel. In patients with hypoplastic types of melanogenesis imperfecta, there is sufficient enamel available for bonding composite resins. However, the hypocalcified variety of melanogenesis imperfecta, the enamel is usually insufficient for direct bonding. Despite this, with the continuous development of dentine bonding agents that have undergone a lot of evolution and the newer composites available, treatment could still be done. So another article published in 2022, it showed they use nanohybrid and nanofill composites for restorations. In another article, a primary dentition was restored, and we have shared this we have shared this article, this case in a which was published in the Dental Practice, and the the cases, the photographs that I'm going to show you here, they contain even some more uh, uh, clinical photographs that have been taken after this case was published. So back to back to the quadrant-wise assessment. You can see, my apologies, you can see in the maxillary right quadrant, 5.4, 5.5, there is an intraoral sinus, and the radiograph shows that the restoration that we have done earlier, it has had an avalanche effect into the interdental spaces. And because of that, there is the decay of 5.4, but there is a thick dentinal barrier in 5.5. So first, this part was removed, and there was a lot of hemorrhage. We started the endodontic treatment under rubber dam. 5.4, the partial pulpectomy was initiated. Now, despite our best efforts in using hemostatic agents, the restoration in 5.5 was still contaminated with the ooze, and we did not get a good restoration here. So we did the close dressing, and you can see the restoration better here. In the subsequent visits, 4 or 5 days later, we did the sealing of the root canal, and the previous restoration was removed because now we have better control over the ooze. There's no ooze now. So now for the restoration, I've used a customized T-band fence T-band matrices. Now they are the best that can be used for deciduous teeth. because all decisus teeth have a cervical bulge, and it's very difficult for all other mattresses to adapt. So the best that I've found so far is the customized T-band mattresses as shared by Finn. So the edge and bonding agent applied, and the first layer that you can see after we have cured over here is that of a flowable composite, the flowable nanocluster composite. Subsequently, the paste form composites have been used to restore the tooth, and the tooth immediately after removal of the rubber dam. You can see the restoration here and compare it with this restoration that we done earlier. So it's much better. The radiograph taken. Acha, one more thing, with the radiographs, you can see if you're developing teeth, but the outline is not smooth. So the permanent dentition is also affected with emergence imperfecta. And you can see the restoration, that is, there's a good dentinal barrier and the pulpectomy that has been completed. 3 months later, the child came back with the swelling in relation to 5.5, but the restorations are intact. So the pulp has undergone a necrosis. We opened up for a partial pulpectomy, which was done, and the access was restored with a nanocluster paste form composite, and can see the radiograph post after we had done the restorations. So 11 months later, the restorations are doing very well. The marginal integrity and everything is going on very well. And 2 years later, after these were treated, you can see that the the restoration margins and the integrity of the restoration is still doing very well. The 5.4 is beginning to exfoliate now, and we have the restoration. So we have been able to conserve there's been no degradation of the restorations. Now, coming to the maxillary left quadrant, that is the decay involving the proximal of 6.4 and 6.5. The radiograph shows involvement of 6.4. The 7.5, there's a decay, but not involving the pulp. So we restored the 6.5, and 6.4 is taken up for partial pulpectomy. The restoration here, now this we have used as a nanocluster paste form composite, whereas this has been restored by a nanocluster flowable composite. So this is immediately after the removal of the rubber dam. Radiograph taken after post the pulp therapy and reconstruction shows the restorations have been doing very well. 11 months later, both the restorations are still doing good, and the radiographs still shows that there is the marginal integrity is gone very well. A few months later, when you compare, the restorations are still doing very well. And 2 years later, what we see is that the restorations that were done using nanocluster paste form are still doing well, and so did the nanocluster flowable composites. So now you can compare this image with that, what we the pre-treatment image, and you can see the difference that over the 2 years that there's been no loss or need to repeat our restorations again and again. Now the mandibular left quadrant, the 7.5 had been undergone a partial pulpectomy. So this restoration was done in January, and about 10 months later, though the integrity of the restoration appears to be good, the tooth structure, which is a softer enamel, has broken off at the distal buccal line angle. And the radiograph shows that the partial pulpectomy and the restorations are doing good, whereas the restoration, you can see there's a recurrent decay involving the pulp. So now the 7.4 needs to be taken up for a partial pulpectomy, which has been done and restored with composite. You can see the restoration immediately after this thing had been restored. 2 years later, again, after the restoration, though restoration has been maintained, My apologies. There's again the tooth enamel has fractured at the distobuccal line angle. Now, the mandibular right quadrant, the restoration that we had done initially has given way, and this time we decided to take a radiograph. So the decay is involving the distal occlusion, but not involving the pulp. But because of the food that got impacted here, there is a recurrent decay below the radiopaque restoration, and that has gone into the pulp. So now the 8.5 needs to undergo a partial pulpectomy, and the 8.4 was restored using composites, nanocluster composites. So you can see as we progress how now the 8.4 has exfoliated and the restoration 8.5 is still going very well after 2 years. Now, just a review uh, how these have helped us to conserve the leeway space of NANS. This is before treatment and this is after treatment. You can see that there's enough space for the premolars and the canines to erupt. And it's also allowed us to have a U-shaped development of the arch. And in the lower arch, this is before. This is the incisor that is present uh, lingually, and it has started to move labially. There's enough space for all the teeth. So in the first clinical case, I shared with you the longevity of a composite restoration lasting from 16 months to 5 years. And in the second case, even in case of a compromised enamel, as is in case of a hypocalcified amelogenesis imperfecta, the restorations have done, and we have allowed the eruption of teeth so that there is no collapse of the arches and the patient would benefit. Now, in the future, we would need to think as a permanent dentition erupts and it comes into occlusion, we would need to restore all these teeth using some form of lithium disilicate crowns. Uh, we The family had gone just a month ago to Amarnath Cave Yatra. Um, this view is at the Ganesh Top. So Ganesh Top is the place where when Lord Shiv moved towards the Amarnath Cave, he one by one he started to leave the things that were very dear to him. So at Ganesh Top, he left his son Ganesh, and it's very difficult for a parent to leave their child and move on. But today, uh, we find that the parents are more attached to their children and very protective. So that is causing a lovely challenge to all of us pediatric dentists today. Now, as we proceeded further, we have this, it's called as a Sheshnag Lake. This is the lake where Lord Shiv is supposed to have left the poison in his throat away. So people say that this lake is poisonous and no one drinks water from it. But and uh, though it looks so beautiful, but no one drinks any water from this lake. And studies have found that this lake, the water has a very, very high levels of fluoride. So something that relates to us. So on this journey, it was very interesting to note that why people felt that this lake is poisonous. Coming to my third case, where a 10-year-old child came to us with a decay of 7.5. So this is where I will share with you step by step how I go about restoring uh, a tooth even after doing a pulp therapy. So decay, DO, the contact points are badly gone. Radiograph reveals that the roots of 7.4 are resorbing and the 3.4 is in its adaptive pathway. But 7.5, the decay is involving the pulp and the roots of 3.5 are even less than one-third formed. So we decided to do a pulp therapy. This is the first visit where we did the chemomechanical preparation And in the subsequent visit, where we checked, when we reopened the tooth, we found that there was very good healing. Now, this is what I was sharing with you. Now, in this case over here, you can see the abnerated dentine. So we have not gone about removing this. So once the root canals were sealed, you can see a darker hue of abnerated dentine here. And okay. Uh, Now I reconstructed the base using a yellow colored GIC. The advantage of this were twofold. One, it gives me the advantage of using it as a sandwich restoration. And second, when I use a yellow colored glass enamel cement or reinforced glass enamel cement, I will have a better ability to reconstruct the tooth aesthetically and biomimetically. So again, the T band was placed after the H and the bonding agent applied. The first layer was that of a flowable composite, whereas the second was that of a nano cluster paste form composite, the Z350 XT. The radiograph over here shows that you can see very clearly that there's such a beautiful adaptation of composite to the walls of the tooth. And this radiolucent area is the abnerated dentine, which will calcify on its own and will not be a problem. Now, but today I would, if I feel that I would like to use a lesser time, I would love to use a nanocluster flowable composite in probably 2 or 3 increments. The advantage is that one, the nanocluster flowable composite is quite viscous. I can use, I can sculpt it, I can create an incline, and to some extent, I can recreate the morphology also. So I'm sharing here 4 graphs. The first 2 graphs indicate that the nanocluster flowable composite, that is the Filtech Supreme, has a higher breaking point and it can absorb more energy before it fractures. So the third shows that it has a very good flexure strength of 139 megapascals and a fracture toughness almost similar to that of normal composites, the paste form composites. So we can use the nanocluster flowable composite, it save us time, and at the same time, it can allow us to reconstruct tooth and can last, as I shared in my previous cases, for a longer period of time. So, moreover, in one visit, I don't have to call my patient back for a crown. And in that visit, I can reconstruct the tooth, which is going to be longer lasting. And we require the dentistry to last for at least 6 to 7 years till the age of, say, 12 to 13 or 14 years until the tooth is ready to exfoliate. And at the same time, not allow any loss of leeway space of NANS. The tooth in occlusion after restoration. And look at this. I have achieved a biomimetic reconstruction of the distal second molar with proper morphology recreated. And as shared earlier, this restoration will last and the tooth will exfoliate normally. Now, continuing with our journey to Amarnath Cave, look at the beauty that is there in our state. And I welcome you all to this beautiful place. There's so many areas for one to visit. And it is a fantastic view that at times I feel we have so much beauty in our own country, much more beautiful places than what we see photographs from outside India. The fourth case is the case of reattachment done post-dental trauma. Now, we get a call in the month of March that from the parents that the girl child who's 10 years old has fallen and she's broken her front tooth. front teeth. So when I asked them about the age, I understood that most probably it is the permanent central incisors. So I asked them if they have the fragments, the fractured fragments with them. They confirmed that they have that. And the next thing is I requested them to put it in cold water or cold milk, and I asked them to come as soon as possible. So at that point in time, I was informed that they are from a village about 40 to 50 kilometers away from the city of Jammu, and it'll take them 2.5 hours to reach. So we told them to come, and we prepared accordingly. Now, why did I mention the month of March? Uh, the month of the months of January, February, and March are very cold in Jammu. And as compared to, I remember my time at Manipal, where in the months of January, February, we would have our fans running at full speed. It was to be so warm. So we had the ideal conditions, and the when the child came, this was the condition that she came to us in, and the teeth were fractured in this way. Now, the golden hour is important. And as Anderson said, the acute phase is the first 24 hours. And if all the parameters are good in our favor, we can also do the same work that you have to do in the golden hour in the acute phase. So the climatic conditions were good. The tooth, the fractured teeth fragments had been placed in the medium. And when the child came to us, this is the incisal view, we can see just a pinpoint exposure of the pulp. And this you can see is, a little bit of blood that uh, has oozed out, but there's no further oozing of the blood. So what we did, we washed this with normal saline, and the radiographs, thank God, thankfully, they did not show us any root fractures. And the periapical changes was the slight some periapical changes that were evident of post-trauma concussion. Can see the pulp chamber is quite close to the fracture line. Uh, the fractured components, and so what we did, we etched these two and placed the bonding agent on these. And in relation to 1.1 and 2.1, we only very carefully etched only the tooth enamel, and we did not go into the dentine. So after having washed off the acid etch carefully, isolated the teeth, we used very small cotton pledgets to very slowly and carefully remove the excess water from the tooth enamel of 1.1 and 2.1. And once we got a little bit of the post-etch pattern on the enamel, we placed the bonding agent on just the enamel, and we used a flowable composite. In 2013, we had a flowable composite that we were using quite extensively. It's called as Z350 flowable composite from 3M SP, and we bonded and reattached the tooth immediately. The radiograph taken shows a very good bond reattachment to the fractured components back. You can see the closeness of the pulpal horns. The periapical changes are very minimal from this angulation. Now, there are different techniques that have been used to reattach fragments. So what we used was a simple conservative reattachment, and this case was also published in Dental Practice Journal last year. So the teeth immediately after a reattachment, and you can see the incisal view, how beautifully and well adapted the fragments are when you use the flowable composite to reattach the teeth. Now, we asked the child to come back after 3 weeks for a review, but the child came back 5 weeks later. And why? Because she had exams. So, uh, when she came back 5 weeks later, the label view was like this, and the incisal view was like this. So she's been extra careful not to bite, it appears. Uh, but when he took a radiograph, we did not see any significant periapical. It appears as if the periapical area is healing. Now, we requested the parents that they should come back every 8 weeks, once in 2 months for a review, where we'll take x-rays and see how the tooth is progressing. But as it happens in our country, the child disappeared. The child came back to us 12 years later. And I was so happy to see the reattached fragments doing still so well, even 12 years later. No doubt, this internal sinus is of concern, but I was happy that the patient has, after even after 12 years, there is no loss of the reattached fragment. And now the child has become an adult. She's become a very fond child, or I'm sorry, a tea drinker, and you can see the tea stains on the palatal aspect. So we took a radiograph, and the radiograph can see the periapical changes. Now, post-trauma, we should have seen some changes in from pulpal response in the pulp chamber and the canals, and there are none. You can still see the pulpal horns. But of course, the pulp has undergone necrosis. We don't know when in this journey of 12 years. And we opened the tooth, started, this is a working length, that's a master cone. And that is the post obturation where a lateral condensation technique has been used to obturate the canals. After the obturation has been done, the internal sinus has healed, and I just polish the surfaces a bit to have such a beautiful effect even 12 years after, also after of the post reattachment. So now, how many of us would have placed a crown after reattachment 12 years ago? And if we would attach, if you would have placed crowns there, what would have happened? Can you let me know what would have happened? I don't see your chat box. So now, another case where someone has placed a porcelain fused to metal, you can see the teeth have erupted. Now the margins have become exposed, and there's a recurrent decay there. Another thing, the teeth have undergone a change in the shade. So now these two front teeth look bagged. So we removed these because the whole it was a full full crown. So we had to do the crown preparation accordingly. Had it been another patient where the porcelain fused to metal crowns had not been placed earlier, I would have preferred to just place a veneer. But in this case, we gave them lithium disilicate crowns to restore the aesthetics of this patient. Way back in 2000, Dr. Anil Arora introduced FAMDENT journals, and they became, it was in, remember, somewhere in April 2020, and there's a call for papers, and Dr. Ritu and I, we sent our first case to FAMDENT, and it got published. So the paper was, the article was titled Pedo Aesthetics, and I never knew that this small journey will lead me to what I'm doing today. So now this is a case of post-dental trauma reconstruction. Now this is a teen who had fallen a flight of stairs and broken. Now someone had done the restoration of this child for the proximal of 1-1 and 2-1, the conjoint filling, and the same filling has been done in both the teeth. So probably when the trauma occurred, it was too much of transfer of the forces onto the other tooth, and the child had come back to us 5 days post-trauma. So there were three challenges. One, the zenith of the cervical margin is higher as compared to that of 2-1. This, and henceforth, the the height of uh, 2-1 is lesser as compared to that of 1-1. The mesodistal dimension of 2-1 is more, and the space that is there with us is less. So we have a challenge here on all the three axi. So, and it is possible to reconstruct such teeth easily with composites. I'll share how. Now, this is the palatal view. You can see the overhang going into the 1-1 area. The radiograph, again, thankfully did not reveal any root fractures. You can see the overhang in relation to 1-1. Slight periapical changes, but definitely there's a pulpal involvement here uh, that we can see. So the tooth was taken up for a root canal, endodontic treatment. This is Dr. Ritu's case, and such beautiful knots we're using a dental floss, only she can do. So a very conservative access she made, and once she did that, you can see the working length radiograph here. The excess overhang can be seen clinically. The necrose pulp came in one piece, so you can see completely necrose pulpal tissue, the master cone radiograph, and the post-obturation lateral condensation done by her. Now, by this time, you can see the overhang has been removed, and we can see a beautiful contour. The previous restoration has been contoured beautifully by Dr. Ritu. So as we proceeded further, this is the label view now post endodontic treatment. The palatal view, we have removed and this is the excess. Now we took an impression of this. You can see how the older restoration has been contoured, and we made it in poured it into a cast. The tooth was reconstructed, and we created a putty index. Uh, I have many videos of step by step, but again, it will not be possible for me to show and share all the videos in this online webinar, but I'm going to share one or two videos so you can understand the process. But if when and if we go in for the an offline course and the hands-on, I would love to share this with you all the way. So the shade match. Now, when you do a shade match, we have to think about the chroma, hue, and saturation. So you can see the chroma is matching. And then we also took in monochrome to assess the hue and the saturation. You can see we have a correct shade match over here. The rubber dam was placed, and now when you use a Z350 XT, the 3M SPA provides a shade match wheel. So we have one for the anterior restoration on the back side, we have for the posterior teeth. Now in this, for an A2 shade, if you see carefully, if you want to use a single shade, you can use A2B. If you want to use dual shades, you can have A3D and A2E. But if you want to use a multi-shade to reconstruct, that I intend to do for this patient. So this is A3D, this is A2B, that is A1E, that is enamel. B stands for body and D is dentine. And C stands for anything that I would like to say, a pallescent or clear enamel that I want to recreate. I also use the bulk fill from 3MSFA to reconstruct the access that we had made. And this A2 nanocluster flowable composite was used at the point where just before I made the palatal shelf for the tooth. So now I took the composites from the dentine, body enamel and made small globules and placed them on the tooth structure. So once again, I cross-checked for my color matching, that is chroma, and a monochrome. Now you can see the dentine shade is always going to be different because generally dentine shades are used for masking. But look at the body and enamel, you can hardly make out that I placed a globule there. So we have a perfect shade match here, and the putty index was cross-checked for perfect fit. The tooth was etched, washed. You can see the edge pattern here. Bonding agent applied. So I use the universal bond from 3M. Now in this video, I'm going to show how I am checking for the fit of the putty index. And in the second video, so see, I know, and see, fortunately, these videos are working, but the one that I shared earlier did not connect. So you can see now I'm putting the enamel onto the palatal surface, and just at the cervical area of this, I'll place some flowable composite and I'll place it onto the teeth and light cure to get a palatal shelf like this. So now when you look at it, an anterior tooth, first we see enamel, then we see dentine, the pulp is there, and then there is again dentine, and then there is enamel. So when I'm going to reconstruct the tooth from palatal to labial, I have to follow the enamel, dentine, the pulp area will have to be replaced by dentine, and then again I have to recreate dentine and enamel. And remember what I shared in the previous slide, that the opalescence or the translucence of enamel varies from incisal to cervical. So at the same time, I have to reconstruct that. Now, this aspect I can share better in an offline mode and with a hands-on, and it's more challenging to share in an online webinar. But I'm sure most of you who are attending will get the gist of it, and it requires a little bit of experimentation to get the perfect results. Now, the proximal areas of the shelf I have not recreated deliberately because I need to recreate the contour of this tooth. So we get these paleodent matrices. I've used them to recreate the contour. We can see in this slide. Uh, that's the contour, and I've added more of enamel to get the perfect contour that I need for recreating this tooth. Now I've added a bit of body, and after the body, I've added dentine. Now the way these composites need to be sculpted onto and recreated to get the natural biomimetic effect. It's very important. The ways to do it. And once again, uh, I am finding myself a bit handicapped to share this online. And the best way would be again an offline and preferably with a hands-on mode if possible. So after that, I've again added body, and the last we've added enamel to create almost a similar face, label face as that of the adjacent tooth. So after this, we use our composite contouring burst, air rotor burst to remove excesses where we feel and start shaping the tooth. Once that is done, this is to get uh, a rough reconstruction. At this point in time, the rubber dam is removed. And once the rubber dam is removed, we have to work on to create the same surface characters as before. Now look at the adjacent teeth. None of the label surfaces are as smooth as say the marble or granite they are having, can see the lamellae here. You can see the developmental grooves here. So we need to create a surface that is very similar. Again, there are different techniques to recreate the surface that is on 2-1 on 1-1. And you can see we've been able to create a developmental groove and even a small uh, notch here to make it look biomimetic. You can see the incisal surfaces. They This is 2-1 and this is 1-1. You can see the incisal edges have been recreated. Now, this when we are treating a child and we need to reconstruct, such reconstructions take about 60 to 75 minutes. And once these 60 to 75 minutes, but if I'm documenting the case, it can extend to roughly to uh, 1 hour 45 minutes or 2 hours. And in 2 hours, honestly, the clinician may also be tired, but more importantly, the patient gets tired. So if you feel that the patient is getting tired, we you can send the patient back home after checking the incisal guidance. There should be no high points there. And you can see we've been able to recreate the lamellae effect onto the this adjacent to structure. So once the child goes home, comes back after 24 hours, the restoration gets hydrated and one can see even better how to finish off the restoration. So you can see how the restoration has been recreated and to look a biomimetic effect. Now, composites is something where we have to understand the science and where the artistry meets. So you can see the reconstructions that can be done use in. So what are the takeaways for all of us today from this webinar? The first uh, is that composites can give long-term outcomes. Second, one should know the material that one is using. Even if I'm using glass enamel cement or I'm using the kind of composite that I'm using, single shade or I'm using a multi-shade, as a shade that the color match wheel, even if one wants to use a single shade or dual shade, you use that particular body or enamel shade, we can get the results. So are we using what kind of a material component we are using? So now, as I shared in one of my previous cases, I've used a non-white glass enamel cement to reconstruct so that my aesthetic effects are much, much better. A good isolation. Honestly, I've shown cases with you, which is having using rubber dam, but not all of my patients allow me to place rubber dams, or they're not in a condition to allow me. So even if you use a good isolation with a high volume suction, that would be suffice. But the isolation has to be maintained. The light core systems. Now, most of us are using a non-standardized light core systems, which are less expensive, and they do not give us a good constant outputs. So I would always prefer using light core systems. I've been using light core systems from Satellac and from 3M SP. Another very important aspect is to use oil-free air from now most of us, uh, the very few of us are using oil-free air compressors, and that does not allow a good bond with the tooth structure, and that's why most of our restorations tend to fail after some time. Flowable composites today have almost the same strength as the conventional paste form composites. So as I shared, if I have to reconstruct a pediatric tooth faster, I would love to use a nanocluster flowable composite. So composites should always be used or placed incrementally. Unless I'm using a bulk fill composite, I would still prefer using them so as to minimize the polymerization shrinkage or decrease the C factor. Composites, when used to restore density tend to last longer than other materials and do not allow the loss of leeway space of NANS. So in all these five cases, I've been able to show you the longevity of the composite restorations in normal enamel from a minimum 16 months to 5 years. And in case of that hypoplastic emulsions imperfecta, uh, it has lasted for a minimum of 2 years. And so this ensures the least chances of developing malocclusion in the posterior region, thus minimizing uh, interceptive pediatric dentistry or corrective orthodontics. Composites can be easily placed in children with all the protocols followed, and composites, especially flowable composites, have a greater breaking point and can always be repaired if there is a restoration failure or a fracture. Fine. So the smile of satisfaction in the child once the child saw that his tooth has been restored. Uh, Thank you, everyone. And we would love to have you follow us. These are our social media handles. Please follow our social media handles. You can also come back to us. I have a Facebook. You can send a friend request on Facebook. I'll be happy to accept. My one Facebook is over, and the second part two with the Roman two is there. So, but my humble request is there that whenever we share cases, do share your opinions there. You can have a good interactive session. But beyond that, as I shared, I hope all of you have had a lot of aspects to follow and carry with you to be able to apply in a clinical practice today from this webinar. At the onset, my deepest gratitude to online dentistry for this webinar, to the staff of online dentistry, to Dr. Joby uh, and Dr. Binu for that nudge to be here with you all today. And uh, I honestly feel that this presentation could have been better uh, in an offline mode with the hands-on. So uh, if any of you feel that you need to further come and pick up these aspects about reconstructive composite restorations, can connect directly with online dentistry, and they can have uh, a session where we can share these with you in a better way. Up north, I feel that it has to be some event where probably the online dentistry can have, or uh, even there's a ISPPD conference coming in September. Uh, I would be happy if there is space and the Dr. Gayanandar feels that they can have a pre-conference course on this composites. It can be done there too, but it depends upon their availability of time and space for having the pre-conference courses. But if you feel that you need to, uh, learn the finer aspects of composites in pediatric dentistry, please connect with online dentistry, and I'm sure they will respond with some options. Thank you everyone for being here on a work day and so late. I think the time is roughly around, uh, it's 10:32. It's been a long day for all of you, and I'm open for question and answers if you have any. Thank you.
Okay, thank you so much, sir, for such an insightful and engaging session. I'm delighted to share the fact that today's webinar has received over an overwhelming experience. We have crossed over 200 views on YouTube, and Zoom session has been completely houseful as well. And we
Oh,
have received,
wow.
yeah.
And I would like to share something with you today. This is my first webinar ever.
Okay, that's great.
My first
And
webinar.
and we have completed over 650 registrations so far. That's an
And
incredible participation, and that reflects immense interest in today's topic and has made this program a grand success.
all thanks to online dentistry.
Okay, on behalf of the entire organizing team, thank you, sir, once again for sharing your valuable time and knowledge and expertise with us. And the chat box is now open for all the questions. You can ask it in the chat box as well.
Okay, they are Now, most of the people feel that composite restoration lasts from 1 year. Someone says 5 years, 7 years, 3 to 5 years, 7 to 10 years, 3 to 5, 3 to 5, 3 to 5, 3 to 5, 10 years. Uh, so majority of the people feel that the composite restorations they last 3 to 5 years. Now, I'm sure that after this presentation, you will feel otherwise that they can last better. Uh, Most of the people have not got the restoration, the shade match. Most of them have not got it correct. So that shows that how the multi-shade composites can make a difference. Thank you. One of them said he's not able to see any video. My apologies for that. Dr. Alia Rashid. Uh, Thank you, Dr. Pandit. Thank you. Uh, Thank you, Dr. Swati. Someone wants to see the last slide again. Okay, fine. Dr. Tharian, I'll just come back to. You want to see this slide? Fine. So, coming back to.
So we have one question in our chat box.
Yeah, sure, sure.
So in one of my case, the anterior composite stayed for like 7 years, but the color has changed. What would you suggest for that case?
Can you come again? In one anterior restoration. What
Okay,
is
in one of the anterior restoration composite stayed for like 7 years,
that?
but the color has changed. And what would you suggest for that case?
See, there's only see when we do the composite restorations, when we finish the restoration, we should either apply a little bit of glycerin and light cure the last layer. It's called as an air inhibited layer. So if we don't do that, the air inhibited layer of the composite does not undergo a complete polymerization. So once we do that, the chances of the staining of the last layer decreases. Fine, you can use a Vaseline, you can use glycerin to apply and then light cure it. And uh, in most of the cases, the composite does not discolor. It is just the staining of the composite. If you use the the polishers, the silicone polishers, will get back your the original composite that you've done in a more polished way. But if you feel that it is discolored, then somewhere there is either the light curing has not been complete, or the quality of the air that was used has not been there at all. It is probably there's been a contamination of the oil of the restorative process resulting in the problem.
And so we have another more question in the chat box. So give some insight about the etching time since the pulpal horn is closer.
Ah, I generally use an etch time of 10 to 15 seconds today. That's all.
Is there any more questions left to answer?
Someone says, can you please mention the interdental bone loss cause in case of reattached post-dental trauma? First case. Interdental bone loss in case of reattachment. In the first case, there was no reattachment, there was reconstructions. So only in the third case, we had a reattachment. And oh, well, what the probably the person has joined late, so it's probably the third case. Now that bone loss is not it's the angulation of the radiograph. That's not a bone loss. If you see very carefully, I'll take you back to that radiograph. Just a minute. I think what now probably talking about this slide. Fine, we're talking about this. So now, can you see a slight interdental bone here? So this is the angulation that has caused this. This is not the bone loss. Because if that was so, let's go on to the next slides, and we should have seen a bone loss here too. You know. So there is no bone loss. It is a artifact in the radiograph. I hope. Okay.
Okay, so we have
Uh,
another
yeah. How
question.
many seconds should a bonding agent should be applied on the edge surface? See, the when you place the bonding agent, we are actually supposed to rub it in for at least 30 to 40 seconds before. The more we rub it, the the bond the bonding agent will enter into the prepared into the etched part of the thing and create a deeper bond. So the deeper bond you have, the longer lasting your restorations will be. Can bonding agent lead to stain or not? See, I would not use with the advent of silicone polishers. I would not use bonding agent to at the last in the last layer of the after I've light cured the last layer of the composite. So I would not use that. Some people do, but I wouldn't use it because we got such good polishers today.
Then one more question. I think it's there. Can bonding agent leads to strain or not?
Yeah, that's what I just answered.
Okay,
Because
so
we wouldn't do that at the last.
all right, all right. I think we have came to the end of this session along with the question answer round has also because there is no question left to answer. So anybody having any doubts, please come in the chat box. And I think that's the end of today's session, everyone. So we have come to the end of the webinar, and I would love to express my heartfelt gratitude to Dr. Rajesh Ahal sir for his wonderful session. And I would also love to extend my thanks to all the participants for joining us today, for your active participation and making this session a grand success. So we'll hope to meet you again in our upcoming academic session programs. Until then, stay safe, keep learning, and you everyone have a wonderful day. Thank you so
You
much.
too. Thank you, Dr. Sandra, for being here. Thank you, Online Dentistry.